everyone. Welcome to PRS Grand Rounds. Thank you for joining us tonight. Next slide. Hello, everyone. My name is Saeed Azuri, one of the resident ambassadors, and I really wanted to thank you for joining us for PRS Grand Rounds. So welcome. This is just a reminder to read free articles related to this topic on prsjournal.com, and those articles can be found directly on the home page. Also, be sure to like PRS on Facebook to get updates on future PRS Grand Rounds and also to catch up on past PRS Grand Rounds. Next slide. And some very exciting news, PRS Grand Rounds has been a national award winner, actually multiple awards. And this is truly thanks to all of the lecturers, all of the participants, and the resident ambassadors. So thank you all for all of your efforts. Again, another reminder that all lectures and article collections are archived on prsjournal.com, so be sure to check them out. Next slide. After the lecture tonight, there will be a question and answer session, so be sure to ask your questions by commenting on this Facebook Live video throughout the lecture. Myself and the other resident ambassadors, Ara Salibian and Lindsay Janes, will go through these questions with Dr. Disa, and hopefully he'll be able to answer as many as possible in the time allotted. And just a friendly reminder to try to keep your questions succinct. That way we'll be able to post them live and we'll be able to share them with you, and they're more likely to be selected. Next slide. So without further delay, I am very excited to introduce tonight's guest speaker. And as of July 1, he is my recent attending and mentor, Dr. Disa. Dr. Disa has been an attending microsurgeon at Memorial Sloan Kettering for the past 25 years. He holds the Benno Schmidt Chair in Surgical Oncology. He is also the Vice Chair of Clinical Affairs in the Department of Surgery. Dr. Disa nationally is recognized as the past president for the American Society for Reconstructive Microsurgery and also the Northeastern Society of Plastic Surgery. He serves on multiple editorial boards, including the PRS Journal, which we're here tonight with, and he is a section editor for breasts of that journal, in addition to PRS Global Open and Journal of Surgical Oncology. So thank you very much, Dr. Disa, for joining us tonight. Next slide.
Thank you very much, Saeed, for the kind introduction. It's an honor to be here with the PRS administrative team, with you, Saeed, and with all the participants. Tonight, I'd like to share some thoughts about breast reconstructions in patients with genetic predisposition. Living in the New York area, there's a number of patients who are of Ashkenazi Jewish descent, and we see a number of these patients who have a genetic predisposition, and breast reconstruction in this patient care setting is a common part of our practice. So almost 1.4 million women are diagnosed with breast cancer annually, and there's about 450,000 deaths worldwide every year. And if you look at this table, you'll see that the incidence of breast cancer is highest in North America and trends to Australia, New Zealand, and South America. And that's probably largely based on population, but the mortality is fairly consistent throughout the world. Every year, there's 260,000 and 120 new cases of breast cancer. This was estimated in 2018, and there's about 40,000 cancer-related deaths. Breast cancer accounts for 30% of all cancers in women, and the average woman has a 12.3% or 1 in 8 lifetime risk of developing breast cancer. So who's at risk is the question. It's hard to know. We all know someone who's been touched by breast cancer, and this trend will continue. What are the risk factors? Well, there's major and minor risk factors for breast cancer. Major risk factors include age, family history, including genetic mutations, a prior history of breast cancer, ADH or atypical ductal hyperplasia, LCIS or lobular carcinoma in situ, and ionizing radiation, such as patients who've had prior mantle radiation for Hodgkin's disease. Minor risks include early age of menarche, late age of menopause. That increases to 2.8% per year after the age of 50. Patients who are nulliparous or haven't had any children, or a late first birth of patients over 30 years, and postmenopausal obesity. If you look at the risk of breast cancer stratified by age in women, you'll see that the younger the patient is, the lower the risk is, but this increases such that it's 1 in 227 for patients between the ages of 30, 40, and this jumps as high as 1 in 28 for patients in their 60 to 70s with a 1 in 8 lifetime risk to age 80. And family history may not be enough to explain why there is this higher incidence of breast cancer. If you look at this graph, you'll see that patients without the BRCA mutation have the lowest cancer risk. Family history increases your cancer risk, but add a BRCA mutation, and your cancer risk is approaching 70% in your lifetime. Red flags for hereditary breast cancer and ovarian cancer include breast cancer before the age of 50, ovarian cancer at any age, male breast cancer at any age, multiple primary cancers, Ashkenazi Jewish ancestry, and relatives of a BRCA mutation carrier. So the breast cancer gene was diagnosed or found and discovered by Mary Claire King, who identified the BRCA mutation in 1990. And this was a Newsweek article that shows a patient and her daughter where this was diagnosed, and the dilemma of what do we do with the young child who's 5, and will she be spared from breast cancer or not? So it's now well established, as documented on the following slides, that at least 10% of all ovarian cancer are hereditary, with BRCA genes contributing to approximately 90% of hereditary cancers. And a very small percentage are attributable to the HNPCC or yet to be discovered susceptible genes. The cumulative risk for breast and ovarian cancer in mutation carriers has Kaplan-Meier estimates of in the analysis. Um, if you have a BRCA1 or a BRCA2 mutation, your risk of developing breast cancer by age 80 is roughly 70%. And your risk of developing ovarian cancer by age 80 is 44% for BRCA1 carriers and 17% for BRCA2 carriers. The Angelina Jolie effect is something where Angelina Jolie identified with a genetic predisposition breast cancer, did risk reducing mastectomy. She raised awareness about the genetic predisposition. She reduced the stigma of having a risk reducing mastectomy, and she emphasized the importance of genetic counseling and genetic testing. So the current NC and the National Comprehensive Cancer Care Network guidelines, their version 2021, goes over the genetic testing process. And if you look at the genetic variants, you can see that BRCA1 and BRCA2 carry a very strong predisposition to breast cancer, as well as an increased risk for ovarian cancer. There's also an increased risk for pancreatic cancer and other cancer risks with these two mutations. There's multiple other genes that get tested for, such as BRIP1, that has a strong risk for ovarian cancer, CDH1, CDKN2A, and the CHEK2 mutations all increase risks for breast cancer. Multiple other genes are identified that show some evidence of increased risk, but not as strong as BRCA2. And finally, the PALB2 mutation, which also is another strong indicator for developing breast cancer in someone's lifetime. So at MSKCC, when patients get screened for genetic testing, the major genes that they're looking for are BRCA1 and 2, ATM, BARD1, BRIP1, CHEK2, PALB2, and RAD51C and D. And you can see that the major link cancers associated with these are breast, ovarian, pancreas, prostate, colon, with breast being the major player in all of these. So what are the best preventative options? Well, prophylactic surgery remains the most efficacious modality for reducing both breast cancer risk and breast cancer mortality. We know bilateral prophylactic mastectomy is effective in reducing risk among high-risk women. Data from a Cochrane database review reported an overall 90 to 94% reduction in breast cancer incidence among high-risk women undergoing prophylactic mastectomy, with an associated reduction in breast cancer mortality. And the surgical aspects of bilateral prophylactic mastectomy include total mastectomy, which is initially skin sparing with removal of the breast and nipple, with an aim to remove all the breast tissue. However, newer techniques include nipple sparing mastectomy, which the rest of this talk is going to largely focus on. And this arose from some dissatisfaction with the available nipple types of reconstructions, the tattoos, the lack of projection, and the fact that reconstructed nipple just doesn't look as natural as a natural nipple. And current studies have demonstrated the feasibility and safety of nipple sparing mastectomy. Although the follow-up is relatively short in the grand scheme of things, with more passage of time and more bilateral prophylactic mastectomies that are nipple sparing being done, it clearly is an efficacious procedure. So the main interest with this is through PROs, patient-reported outcome measures. We saw that patients were more satisfied with a nipple-sparing mastectomy and a reconstruction compared to a non-nipple-sparing mastectomy and reconstruction, with definite improvement in psychosocial and sexual well-being. The surgical approach to nipple-sparing mastectomy has been championed at multiple institutions, but Virgilio Cecchini at our institution showed that by leaving a 3 millimeter nipple areola flap, you can maximize the reduction of breast tissue while still maintaining a viable nipple and areola complex. And the priority here is there's no breast tissue left. And you can see in this slide here that there's multiple different surgical approaches. And I'm going to highlight some of these and show you some of the pros and cons of these different incisions and different approaches. At the end of the day, the quality of the reconstruction is predicated on the quality of the mastectomy. Periareolar incisions have an advantage of excellent access to the nipple and areola complex from the general surgeon and remaining breast tissue and a fairly inconspicuous scar. The disadvantage is you need a larger diameter areola, and because there's an incision adjacent to the nipple and areola, it may lead to the highest instance of nipple areola ischemia postoperatively. And oftentimes with a smaller areola, you need a lateral extension of this scar in order to properly do the mastectomy and the reconstruction. And here's a patient who's pre-op with a larger diameter areola who's going to have a bilateral nipple sparing mastectomy. She's a relatively young woman. She has her periareolar scar that you can see here. The nipple and areola remain viable. I apologize for the black dots covering the nipple, but it's necessary for the live live presentation of this topic, but it will highlight the nipple areola position very nicely. Here's this patient with tissue expanders. She's fully expanded and getting ready for her exchange. And then here's after she's exchanged to anatomic silicone implants in 2011 when they were still available and on the market. And here she is preoperatively and postoperatively 6 years post-op. That's her pre-op photo. This is 6-year post-op with nipple sparing mastectomy, anatomic implants. About this time, she received the letter that said that there's a ALCL or anaplastic large cell lymphoma risk with a textured surface implant. So she's a young woman. She wanted her textured surface implants out, and they were switched to extra high profile cohesive gel implants with some fat grafting. This was done in 2017. And then here she is with a lateral view or oblique views in 2017. And then 1 year later in 2018. You can see her nipple position is good and the scars are very inconspicuous. Another patient, 2015, is going to had developed left breast cancer, found to have a BRCA mutation, does a bilateral mastectomy, periareolar incision with a slight lateral extension, so the breast surgeon could do their job properly, and we could put the expanders in without any issue. This is her with her tissue expanders in place. Exchange to soft touch full projecting silicone gel implants in 2018 with inconspicuous scars and a nice result with a natural appearing nipple and areola. Another patient, again, risk reducing mastectomy. She has her expanders in, periareolar incision with the lateral extension. The scars tend to get a little widened during the expansion process due to the tension on the skin, but you can revise that when you do your exchange procedure. And here she is exchanged to anatomic round base implants. The An important point in these patients, as with all breast cancer patients, it is a cancer operation, and the aesthetics are extremely important. But particularly in these patients that are young and have a genetic predisposition and their life ahead of them, um, they're having an operation done to prevent cancer, not because they have cancer. And genetic or cosmesis is on the forefront. So the ability to do nipple sparing mastectomies in this patient really helps with the aesthetic outcome. Lateral incisions are often used. These have the advantage of excellent access for the breast surgeons. The breast surgeons really like this incision because they can access the whole breast safely, and it's really easy to remove ductal tissue from the nipple. The disadvantage is it may affect the blood supply to the nipple. The scar is somewhat visible as it extends laterally, and contraction of the scar can lead to nipple areola displacement, and I'll show you some of these examples. So here's a patient preoperatively. Here she is post-operatively with a moderate profile silicone implant about 3 years post-op. Her nipple position's reasonable, the scar is reasonable. You can see on this image here that the nipple seems to be dragged a little bit to the left side. That's a combination of scar contraction and trying to get the implant medial enough to maintain some nice cleavage or décolletage for this patient. Another patient in 2016 with a lateral incision mastectomy. And here she is post-operatively. Nipple position's pretty good. This one's dragged a little bit laterally. She had SRF full height silicone implants placed after a two-stage tissue expander approach towards breast reconstruction. During the second stage of these operations, I often do fat grafting to soften the contours and to improve on the rippling and to make the transition on the upper chest wall to the breast reconstruction look more natural. That's a very common part of my practice. Another patient who had a prior augmentation mammoplasty found out that they have a BRCA mutation. We did a single stage direct to implant reconstruction with 605 cc implants for her, lateral incision in its early stage. Another patient with a two-stage reconstruction. You can see where in this situation, pre-op and then post-operatively, how much lateral displacement of the nipple from a combination of scar contracture and then just trying to medialize that device a little bit to improve upon her cleavage, which she desired. So we narrowed her cleavage a little bit here compared to her pre-op image. That plus this scar contracture serves to drag these nipple areola complexes a little bit lateral. Unfortunately, because it's a mastectomy, the nipple does not slide medially. So in order to reposition this more medially, you either have to do a little crescenteric mastopexy to try to move it over. You can do a pedicle it and rotate it 180 degrees. That'll get it a little bit more medial. Or in occasional cases, I've gone as far as taking it off, closing this as a straight line, and putting it on as a free nipple graft. That typically works well. These patients are asensate for the most part after a mastectomy, so you're not worried about losing sensation with a free nipple graft. Another patient with a two-stage expander implant reconstruction converted to full profile silicone gel implants. Her nipple positions maintained relatively good. Her scar contraction was fairly minimal. We did not make a big effort to change the wide space between her two breast implants compared to her natural breast. Another patient with a direct to implant reconstruction and high profile implants, a little bit of nipple malposition that you can see here and here. And the same thing here, more significant nipple malposition, all demonstrating that this lateral scar works well, but it's a little less than ideal due to the natural scar contraction that occurs. And another one with some more severe nipple areola malposition that you can see a little bit here and then more significantly here. So the best method of doing this operation whenever feasible is an inframammary fold incision. It's a little bit more challenging for the breast surgeon, particularly accessing the upper inner aspect of the breast. If you have a large breast, this leads to longer flaps, which can potentially lead to more ischemia, particularly just above that incision. There's sometimes some retraction injury that can happen as the breast surgeon's pulling hard to try to get up to the upper inner pole. Um, but if you have an adequate length incision, you can certainly try to make this operation better. Typically, I like an incision that goes roughly from 6 o'clock to 9 o'clock, and that gives a breast surgeon adequate exposure. As you can see here, it's kind of hidden in the inframammary fold. You got a good scar and good nipple position, and then we do our best to keep that natural fold, keep that scar in the natural fold. Here, the implant drifts a little bit medial when she has her arm elevated, but otherwise, it's very difficult to see that incision. Another example of a patient preoperatively and postoperatively after inframammary fold incision, maintenance of good nipple position, pre-op and post-op, and a highly invisible scar. Same thing here, pre-op, post-op, clearly the most natural scar for doing this operation. Here again, pre and post. This was a two-stage reconstruction. If the patients want to be the same size, you can typically, or a little bigger or a little smaller, you can potentially do this in one stage if the skin flaps have adequate vascularity. If they want to be bigger, then we typically do it in 2 stages. Same thing here, pre-op and post-op, a little tiny bit of nipple malposition, but that's because she wanted her device to be a little bit more medial, which is what we did here, and that caused the nipple to ride a little bit laterally, but there's no component of scar contracture. Another example of pre and post, two-stage, wanted to be larger, maintenance of good nipple position, relatively invisible inframammary scar. Again here, same thing, two-stage reconstruction. This one's with a saline implant, overfilled a little bit to minimize on the ripples. Another two-stage reconstruction with a highly cohesive device, still has a little bit of rippling. Fat grafting can help with this. And this is pre-pec. I do these both pre-pec, sub-pec, partially sub-pec, with alloderm, without alloderm. Everybody's individualized depending on their needs, depending upon the mastectomy skin flaps, and figure that out in the OR based on what I'm left with. I'll often use a SPY if I'm concerned about the viability of the nipple or the viability of the skin flaps to check the blood flow. In another pre-op, and post-op picture with an inframammary incision. Nipple sparing mastectomy and autologous reconstruction can also be done. Example of a patient preoperatively and then post-op with a bilateral deep flap and nipple sparing mastectomies. Oftentimes with these, you need a more medial incision to get access to the blood vessels, or a more incision that's more lateral and extending around the areola, so you can get to the mammary vessels to do the microvascular anastomosis. Same patient demonstrating her abdominal scar and the fact that the midline scar doesn't preclude us from doing a bilateral deep flap. And here she is post-operatively. Another example of a bilateral pre-op and post-op breast reconstruction with a bilateral deep and a nipple-sparing mastectomy. And finally, sometimes our best efforts at nipple-sparing mastectomy don't work out so well, and we end up with a situation like this with bilateral mastectomy, skin flap necrosis, and nipple areola necrosis. And then this patient ultimately went on to have a nipple areola tattoo and reconstruction. So with that, I'd like to thank everybody for their kind attention, and I'll be here to entertain some questions. And thank you very much.
Hello, everyone. Thank you very much, Dr. Disa. I learned a lot, and thank you to everyone who joined us here tonight. This is just a reminder that there are articles for free on prsjournal.com, on the prsjournal.com website on their homepage, and you can read all these articles for free. Next slide. And this is also just a reminder to post your questions live to this Facebook page, and we will try to go through them. Be sure to keep them succinct so that we will be able to feature them on the screen, typically less than 120 words if possible. And thank you very much, Dr. Disa. And we will now turn it over to Dr. Disa for the question and answer portion. So, Dr. Disa, the first question we have tonight is from Aris Alibian, actually one of the other resident ambassadors, one of the microsurgery fellows at University of Southern California. How do you approach potential nipple-sparing mastectomy with difficult morphology, like the large entodic patient?
That's a great question. I think there's really two ways to do that. The most common way we do it is to do a preoperative breast reduction or mastopexy, and then 6 months to a year later do the nipple sparing mastectomy and then the reconstruction. That's been shown to work by multiple authors, including Scott Spear and Nolan Karp. And I'd also like to point out an article that is published in the last year in the journal by Dr. Ali, the brothers Ali and Tamer Moshe from Scottsdale, Arizona, where Ali showed his technique of a long adipofascial pedicle, maintaining the nipple and almost doing a mastopexy with that, with a wise pattern mastectomy. And that works well also. And I would encourage the readers to take a look at that article as well. And those would say those are the main three ways to do it.
That's great. Thank you very much. Our next question is from Josh Cohen, one of the members of the Resident Advisory Board. Thank you, Josh. What percentage of your patients are direct to implant reconstructions? And do you find you are more likely to perform DTI based on which incision is used?
I would say that about 20% of my patients are DTIs. And I think that you need several things to do a DTI. You need a patient who wants to be, as I mentioned earlier, the same size, slightly larger, slightly smaller, or a patient who's going to, if they're having a nipple sparing mastectomy. If they're having a traditional mastectomy and they're okay being smaller and you can just excise more, a larger skin envelope, then that works for sure. And then I would say it's not so much based on the incision, it's more based on the quality of the mastectomy skin flaps. And that's completely determined by the breast surgeon.
Yeah, that's a very important point. Thanks, Dr. Disa. Next question is from Karen Liu. And I know the answer to this just because I've been working here, but do you use SPY to assess your mastectomy skin flaps?
I do. I mean, I use clinical judgment as first choice and then a SPY if needed.
Great. Next question is from Chris Holmesy. Hey, Chris. Chris is one of the members of the Resident Advisory Board for the past several years as well. He states, you mentioned modifying the lateral incision to extend a little medially. Can you comment on choosing an inferior incision rather than lateral?
So that's a really good question. When we started doing nipple sparing mastectomies, they were doing everything from transareolar, periareolar with a lateral extension, an omega incision. And then our breast surgeons got really super comfortable with a lateral incision because of the comments I made earlier that you can access the breast very well. They feel comfortable getting all around the pocket. They feel comfortable dealing with the nipple and the areola. But then you start to look at your long-term results and you see the lateral nipple deviation from the combination of the contraction of the scar and the medial, trying to put the implants medial enough so the patient has decent cleavage. And that led us to push the envelope a little bit more on the inframammary incision. And most of our surgeons now are very comfortable with the inframammary incision. And typically, if you think of the breast as a clock, I I'll have them draw an incision from 6 o'clock to 3 o'clock or 6 o'clock to 9 o'clock, and use that incision 90 degrees around the perimeter of the breast. And the vascularity is typically good. If the breast is super large, it can be problematic, but in general, that gives us cosmetically the best. So I'd say it's a combination of inframammary, lateral with a perioareolar extension to try to minimize the length of that lateral incision, or pure lateral, again, depending on the needs.
Excellent. Thank you, Dr. Disa. Next question is every reconstructive surgeon's nightmare, but how would you deal with nipple necrosis? Do you use tattoos or try to save it? I guess that probably depends on the stage.
It does. So some of my partners are fairly aggressive if they see an ischemic nipple areola complex with sending patients for hyperbaric oxygen, and they've had some good success with that. I have mixed success with that, quite frankly. We try to save what we can save. What you tend to find with nipple sparing mastectomy is the first thing, if they're ischemic, if they get a little desquamation, you're going to lose some pigment. The pigment cells that are in the skin are super susceptible to ischemia, and they die off rapidly. So you get a nipple where you lose some color, it gets variegated, it gets blotchy. We can tighten that up with a tattoo, and often we'll do that. If the whole thing's necrotic, we excise it and just turn it into a central scar, let it heal, and then either do a 3D tattoo or a combination of a local flap and a 3D tattoo. Used to do a lot of skate flaps with skin grafts. Almost never do them anymore because of the quality of the 3D tattoos that are being done.
That's great. Thank you very much. Next question is from Zoe. Thank you very much, Dr. Disa. How do you approach mastectomy reconstruction for patients with prior breast augmentation?
Those are my favorites. So those patients are great because their breast has been preconditioned to have an implant. And if they've had a successful implant, I almost never do a pocket change. I have the breast surgeons do the mastectomy. If they can leave the capsule around the implant, perfect. And then you have like autologous ADM in there. It's already there. The capsule is vascularized. You can just pop the implant in. You can do a capsulotomy around the pocket to expand it to put a bigger implant in. If it's a nipple sparing patient, I tell them, and let's say they have 300 grams of breast tissue and they have a 300 cc implant, then they're going to need a 600 cc implant to now fill that space. And if there's not a big enough pocket to do that, then you can open up the pocket and then add ADM to it to support it. And those patients typically do really well. And that's for people that are starting to do DTIs, that's the best patient population to learn how to do a DTI on. Somebody with a prior augment.
That's good to know. Our next, another question from Josh Cohen. How do you manage and you showed a picture of this in the presentation, but how do you manage a superiorly displaced nipple postoperatively?
Typically, a superiorly displaced nipple is because of bottoming out of the implant. And you're going to see that more and more as you do more prepecs and the use of smooth implants. As you get some pocket stretch, that's what happens. And the best way to address that is to go back in and do an inferior pole capsulorrhaphy, reposition the inframammary fold in the right place. And I personally have had the most success doing that when I've had some either acellular dermal matrix as a reinforcement of that, or something like Galatea, Galashape, or something that's some absorbable mesh, vicryl mesh, whatever it may be, in addition to your internal sutures to kind of act like a belt and suspenders. That will bring the implant up and bring the nipple down naturally. That's the best way to fix that problem.
That's definitely good to know. Another question from As Lafreniere. How do you counsel patients in choosing autologous versus alloplastic reconstruction? And this is something that I kind of always think about too when thinking about how I would talk to patients, knowing that you don't want to burn bridges, what would be your preferred option?
Again, it's patient dependent, right? So you need to figure out who your patient is, what they're looking for. Not everybody's a candidate for autologous reconstruction. Most everybody's a candidate for an implant-based reconstruction. In my practice, it's probably 70% implants and 30% autologous. I tell patients that if you look at patient-reported outcomes, implant patients are happier in the beginning because it's less stress on their body, but over time, they often need revisionary surgery or implant replacement. And in that setting, the the autologous patients get happier over time because it's more natural, and the longer the time goes, the better that reconstructed breast gets. Um, I have a number of patients who started with implants and then converted to autologous. And Michelle Caridi and I wrote a paper that was published, I think, last year or the year before, that shows how the PRO scores, from the breast Q just jump up when you go from unhappy implant patient to an autologous patient. So I don't think it's burning any bridges. I you never burn a bridge with an implant. With an autologous, you do, I guess, if the flap doesn't survive. Um, but I think the most important thing to do is to properly select your patients. Some patients are going to do better with implants. Thin patients, heavier set patients with a larger BMI or body habitus tend to do better with autologous reconstruction, particularly since they probably have a better donor site for that. But you can make either work. You just got to be kind of open and honest with the patients, and not have a cookie cutter approach to it, and individualize the reconstructive plan for everybody.
That sounds great. Thank you. Next question is from a close friend, Yoshi, another member of the Resident Advisory Board from the University of Pennsylvania. Thank you, Dr. Disa. There were many cases you shared in which you used fat grafting. Do you have any concerns for fat grafting increasing oncologic risk in these genetically predisposed patients? I know that this has always been kind of a debate historically with fat grafting. What's your thought on that, and how do you cancel your patients?
I defer. When we started doing fat grafting, we started talking to our medical oncology colleagues and our radiation, and I'm sorry, and our radiologists who are doing imaging on these patients. And we went from not doing fat grafting to the medical oncologist feeling and the surgical oncologist feeling it was totally safe to do fat grafting. And to the point now where our radiologists are comfortable if we fat graft lumpectomy and radiation patients to help to improve the aesthetics of their lumpectomy deformity. So I don't think there's any literature out there that supports, increasing your cancer risk by fat grafting this patient population. Certainly, if there was convincing evidence, I wouldn't do it. Right? Why would I do that? I work in a cancer hospital. It doesn't make any sense. So I'm pretty comfortable doing it, and unless something changes going forward as time passes and we learn new things, then we change our techniques as a result. But right now, I'm very comfortable with that.
That's good to know. Thank you, Dr. Disa. And sort of another hot topic, and another question that I'd love to hear your opinion on, this whole topic about ADM. How often and when do you use it? And sorry, just to clarify for the audience, ADM is acellular dermal matrix.
Right. So another, I have a love-hate relationship with ADM. It works great for when it works great, but until it's incorporated, it's a second foreign body in a mastectomy space that is a gland. The breast is a gland. The ducts in the nipple are in communication with the breast tissue. By definition, there's bacteria around. You do a mastectomy, it's a semi contaminated space, and you putting in a foreign body, and the ADM is a second foreign body. When you need it, you need it. When the soft tissue cover over the implant isn't good and you need it for support, you need it. If the patient has if the patient has great mastectomy skin flaps, you don't necessarily need it. Um, if they have a long pectoralis that goes all the way down to the inframammary fold, and you're going to put your implant subpectoral, then you often don't need it, or maybe you just need a little piece of it on the side if the serratus has been skeletonized. If there's a nice fatty plane over the serratus, and you can raise like serratus fat and fascia over and use that in conjunction with the pectoralis, then you don't need it. So again, it's a tool. I tell patients that I may need it and I might not need it. I certainly don't use it on everyone or not ever use it. I just have it. It's another tool in my toolbox that I use when I think I need the extra soft tissue support for it. Personally, I think it's safe. I think there may be a slightly higher risk of infection when you use it compared to not using it. But it's there for us, and it can solve problems that you can't solve if you don't have it. So when you do a direct to implant reconstruction, you almost always need it to keep that implant in its pocket, so it sits properly and it doesn't fall laterally into the axillary area, or it doesn't sit too low on the mastectomy flap. With prepectoral reconstruction, I'm not sure if you need it or we don't need it. We're actually going to do a randomized trial here at MSK looking at prepectoral breast reconstruction with and without ADM to find out if it makes a difference or not, because we want to know whether there's a long-term need for it or not. So we're going to ask the question.
That sounds great. Well, hopefully we'll be reading about that randomized trial in the PRS journal. But and I think our one of our second to last questions, just given the time constraints, do you have any recommendations that involve breast size and kind of surgical scar? I know you kind of talked a little bit about ptosis and the large breast, but any other recommendations?
I just think that if the breast is too large, you can't do a nipple sparing mastectomy unless you do something first, or you use one of these techniques where you preserve the nipple on some sort of a parenchymal pedicle that has adequate blood supply. Um, with a very large breast, somebody who's going to have or a very tonic breast, somebody's going to have either a one stage or a two-stage breast reconstruction. I've become a fan of wise pattern mastectomies. And then what I'll do is save a large lower skin flap, and then I'll deepithelialize that. And then I'll use that to kind of drape over the implant in a prepectoral plane, or lift the pectoralis and sew the dermal flap, the inferior base dermal deepithelialized flap to the pec, cover the implant, cover the expander, and then redrape the wise pattern incision over the top so it looks like a breast reduction pattern without a nipple, or with a nipple, depending. That works well with large and very tonic breasts. It definitely works better cosmetically than just a straight old transverse incision in that situation.
Those are some great pearls. Thank you, Dr. Disa. And I think we'll end with this last question, just given the time, from Ronnie Shamas from Duke, another member of the Resident Advisory Board. Hello, Ronnie. He says, thank you for your talk, Dr. Disa. What is your experience with surgical delay of the nipple areolar complex in patients who are at higher risk for experiencing nipple areolar necrosis following nipple sparing mastectomy?
Thanks, Ronnie. That's a great question. My answer is I have zero experience because I've never done it. So I know some of the people in my practice have, and they've had good success with it. In the beginning, when we really started to do more and more nipple sparing mastectomies and pushing the envelope a little bit, we did a few of these surgical delays. And I think now our breast surgeons, when you select the patients properly, and our breast surgeons have gotten fairly sophisticated about doing nipple sparing mastectomy, a delay procedure really I don't think is necessary. And I really haven't had to do it and haven't had a lot of experience. Fortunately for us, the incidence of nipple necrosis is gone down, and it's relatively uncommon.
Great. Thank you so much, Dr. Disa, for all of your time.
It's been my pleasure. Hopefully this was helpful and useful for everybody. And I know that the journal is going to archive it. So, if anybody needs to see it again or whatever, or share it with somebody who didn't get a chance to see it, it'll be out there.
And thank you to everyone who joined, and thank you, Dr. Warwick, and for all the behind the scenes help from Aaron and Maddie. And be sure to like PRS on Facebook and stay tuned for the next grand rounds. Thank you all.
Thank you, guys.